stuff. Right, good morning everyone. Thank you very much for asking me along to speak. Well, you actually asked my colleague Tim Nutfield to come and speak, but he's in Antarctica repatriating someone who's not very well at the moment, so I've stepped into the fray. What we're going to hopefully cover in the next 50 minutes or so is have a little look at extrication and interventions for the trapped patient. So when you think about the trapped patient, I'm thinking primarily along the lines of RTCs. However, also I think this is applicable to many of the fields that you guys and ladies work in at the moment. So this is coming primarily from a medical perspective. So I'm not going to give you information about government funding, etc., etc. I'm looking at things purely from what's good for this patient that's stuck in this vehicle or wherever they might be. So please be gentle with me when it comes to questions. So the objectives that I want to get covered in the next 50 minutes are, we're going to have a little look at why patients are important, and why trauma care is important, and finally why I think all of you are important. And from a fire and rescue service background, I think that you all have a phenomenal role to play for these patients, and I hope that by witnessing this presentation you're going to actually feel even more empowered to go and look after them. So trauma, just in terms to set the scene really, and just to try and reinforce what it is that we're thinking about. Trauma is the leading cause of death for those less than 40 years in the developed world. So this is primarily a disease that affects the young. Okay, so this affects people who have families, who have got long careers ahead of them. This is something that's really, really serious, and it's emotive. I think most of us in this room will have either professionally or in our personal lives come across someone that's had a traumatic injury or ailment forced upon them. So road trauma accounts for about a third of all the deaths that occur in the developed world. So this is a huge part of what we're looking at today, and a huge part of what we should be focusing our attentions on in the future. This equates to around 1,700 deaths per year in the UK, so that's nearly 5 deaths a day occurring on our roads. And of all major trauma in the UK, approximately 20 to 30% will have a significant entrapment. So these are patients that need you there to extricate them from that vehicle so that they can be on their way to a hospital to get those injuries fixed. So you are really, really, really important when it comes to looking after these patients. This is a slide just looking at trauma deaths in general, and if you can see, it starts in 2000, and as you work your way down to the right-hand side, you can see there's a sharp decline actually in terms of the serious injuries that are there. Does that point? So you can see that it starts to quite nicely decline, and that's through prevention primarily, and the work that's been done by ROSPA and the other safety agencies. And that's unfortunately starting to plateau off here. So around about 2008, 2009, 2010, we're not seeing that drop anymore, which sort of says that we've exhausted our options with regard to prevention. You'll also notice that along the bottom, the deaths line doesn't really change at all in that period. So those same patients that were dying in the year 2000 are still dying this day. So what's causing these patients to die then? Well, first of all, think about when they're dying. And this is a very old chart from 1983, but it's still really relevant, really. And you can see that 50% of those 1,700 patients a year die in the first few minutes. So before they even get to a hospital, half of those patients are dying. So these are dying in the environment that they have the accident or incident in. Then there's a bit of a peak in the minutes to hours section. So this is where we've primarily focused our discussions around the golden hour. So this is what we're trying to aim to prevent, is death by airway occlusion or death by blood loss. The final 20% is really aimed at ongoing organ care and prevention of infections. That was 1983, and in 2013, this was produced in Germany, and that shows that really in all of those years it hasn't actually changed that much. We can break down the first hour into sort of less than 24 hours now, but in that first hour we've got 50% of our patients that are still dying on scene. So all of the advances in medical care in the past 30 years haven't really improved survival on scene. So of those people that are dying, about 85% of them are going to die anyway. Okay, these are patients that have had an unsurvivable catastrophic hemorrhage that's internal, and there's no way that we can do anything about it. That could happen in an operating theatre, and these patients will still die. It could be that they've had a massive central nervous system disturbance, so they've lost part of their brain, and they're never going to recover from that. but 15% of patients that are dying at the roadside in that first hour have either absolutely preventable or potentially preventable injury process that can be reversed. Okay, so that's where we need to be focusing our attentions, on those 15%. So let's talk first of all about extrication. Now, extrication is something that hasn't really been studied. For those of you that were at the trauma conference last week, Tim had a very nice slide about this. And if you go into PubMed, which is something that we use to have a look at the academic research out there, if you type in major trauma, it's got 42,000 hits. Okay, so 42,000 bits of evidence out there to go and research and to fine-tune our practice. Now, if you type in fire and rescue service, it comes up with 350, okay, hits. If you type in extrication, it comes up with 45 hits. So this shows that there's not really any evidence out there. To put that another way, ingrowing toenails has 750 bits of research there. So no one's looking at extrication, but clearly they are very interested in ingrowing toenails, which is good. So extrication, well, why is it important? Well, myself, Tim, and actually Vicky and a few others that were in this room have been involved with the EXIT project, and we decided that this is a really important area for our patients. And actually, we need to be looking at it in more depth to see whether or not what we're doing is the right thing for those patients, or is it just based on what we think is probably the right thing. Well, here we've got a timeline. So we've got the incident, so this car crash that happens. We've got a response time, which is essentially fixed, okay, so you can maybe drive a little bit quicker, you can maybe look at having resource in other places, but really without a huge change in the system, that's essentially a fixed time window. You've then got this on-scene time, which is variable, so bearing in mind that these patients are dying within an hour, okay, we want to know how much of that time is taken up by extrication. Finally, we've got the transport time, which is, again, essentially fixed. So we can't really influence where people are having their accidents in relation to where the hospitals are. Okay, so we have to think about this bit in the middle, which is the variable part, which is the on-scene time. And we need to be looking at that in more depth. So just in terms of what's happening during extrication, so what's happening to our patients? Well, firstly, they're not on their way to hospital. Okay, if you've got a catastrophic bleed somewhere, you need to have that measure temporised, but then you need to be on the way to get that definitively managed. And that period of time that they're trapped in a car means that they're not on their way to hospital. They're continuing to bleed. So we can arrest some hemorrhage, we can stop some hemorrhage by using some interventions. But if your patient's bleeding into their tummy, if they've got a ruptured liver or a ruptured spleen, they're going to continue to bleed in that car until they're out and on their way to hospital. They get cold. Now, this might not be actually something that sticks in the front of your mind as being really important, but the body has a really tight window that it needs to operate. And actually, the clotting cascade is affected by temperature. So patients that are sat there in a cold, dark, wet vehicle that are getting cold over time, that has an influence on how easily they can clot, and that also has an influence on how likely they are to die because of it. So as a rough figure, for every degree in temperature that patient gets colder, their mortality goes up by 10%. So we need to be thinking about getting them somewhere warm and removing them from that process. Now, the other thing is advanced interventions can't happen. Now, in a motor vehicle, you can't do the sort of things that many of these patients will need to keep them alive. You can do simple stuff and do it well. It's very difficult to do the advanced interventions that are there. So the on-scene time, Tim came up with this, which is basically a graph. Now, this will move depending on the vehicle and the extrication itself, but the white patch that you see here is the level of interventions that can happen. And as you see, as it progresses, so the more that that vehicle gets open, the more that we are down the line in the extrication, what that will mean is the more advanced interventions that can take place. Now, when we get to the end here, the packaging and assessment is a really fixed time window because it takes a set amount of time to work through someone's ABCs and correct them as we find them. So actually, the bit that's mouldable and changeable here is the extrication process for these patients. So how long does extrication take? Well, about 2 years ago, I used to be able to go around and do a straw poll and see how long it would take, but most people know now. We've done some research in 2011 and 2012 looking at the extrication process itself. And with West Midlands Fire and also with Staffordshire Fire, we found that extrication takes 30 minutes from the time that a vehicle arrives on scene to the time that that patient's extricated. And that really doesn't change that much, in all honesty, and that's for retained, that's for every type of crew that you come across. So what we need to be thinking about is what we're actually doing during these periods of extrication. So in the initial parts of the stabilisation and glass management, there shouldn't really be too much going on in the way of interventions because the vehicle itself is inherently unsafe. And then we've got that takes about 8 minutes. So that's 8 minutes that these patients are effectively dying in front of you, that there's very little happening. Then there's the limited assessment and intervention time, which again is taking 22 minutes. So this is a huge chunk of time. These patients are dying in the first hour before they actually arrive at hospital, and 30 minutes of that is taken up by us extricating. So can we predict the time for extrication? This was something that we had a look at as well. And yeah, you can predict the time, roughly speaking, and using these variables. Cool. Yeah. So as an arbitrary baseline, it takes around 8 minutes for any extrication to occur, and then you can add on factors. And basically we were looking at whether or not you could do this remotely. So this was more around dispatch of appropriate resources. And what we were thinking initially was, are we going to be able to roughly work out how long it's going to take, and then actually dispatch the right resources to that patient? So if they were going to be there for 40 minutes, why don't we get a HEMS doctor there? Why don't we get a critical care team to that patient so that when they do come out, we're ready to go? But actually what you can see, the most important thing I think with all of these is that rapid access shortens our time, okay? So there's ways of shortening this time. And what we need to do is work out whether or not rapid access might be really good for some patients or not. So why do we extricate the way we do? Well, extrication itself is based on some really sound principles, I think, because we want to minimise harm. We don't want those patients to get worse in our care. And what we don't want is a patient that would have made a good recovery. We go hoiking them out of that vehicle, and it turns out they spend the rest of their life in a wheelchair. That is something that we're desperate to avoid, I think we'd all agree, when we look around the room. However, this is not really based on evidence. This is based on what we think of as being best principles. So it makes reasonable sense that if you move someone less, that potentially their injuries are going to be less. But that's not the case. What I would say that we're also worried about is we're worried about getting sued. Okay, we're worried about not being able to pay our family's bills because we've no longer got a job anymore because we made the wrong decision on scene. But no one's actually ever looked at those processes. So this was a book that Tim found from 1975, okay, that describes a standard roof-off, longboard out the back extrication. So that's 40 years ago, okay, and we're still doing exactly the same thing. So why do we extricate the way we do? Well, primarily it's based on dogma. There hasn't been any research that's come out that's told us the best way to get these patients out of these vehicles and in the best time. So there's some new evidence out there. What's different then? C-spine injury is rare, okay, really rare. So 1 in 200 patients has a C-spine injury, okay. Now, 1 in 200 patients, that's nowhere near like the 15% that we were looking at that are dying in that first hour. So the chance of them dying of something else in that first hour is far higher than the chance of them having a C-spine injury. This was a study that was published last year that looked at the biomechanical analysis of spinal immobilization. So what this was trying to work out is, what was the best way to extricate the patient and minimize the movement to their neck? Now we all know what we think of as being plan A. Plan A is a controlled extrication where we take our time, we fit a collar, we take the roof off, we slide them out on a longboard, because we think that's the best way for these patients to be extricated. Well, actually what these guys found was that standard extrication techniques have 4 times more cervical spine movement than the patient just walking themselves out of the car. Okay, 4 times the movement. So what we're trying to envisage is in future, actually these patients, unless you are unconscious or unless there is an absolutely really good reason why you can't get yourself out of the car, that's what we're looking to do. This is something that's going to become more and more apparent quickly as we move on. So what else is different? Well, we've been doing some work, and this is the latest arm of the Exit project, which is some work we've done with Dan. And this is looking at the actual forces. So we know about movement now. So that movement with a standard longboard extrication is 4 times more movement than just them walking out. But what about the actual force that goes through the patient? Well, this looked at a patient, so we tried various different methods, and we attached an accelerometer to the patient's chest. So what we were looking at was how much movement actually occurs to these patients at various points. And all these little squiggles on a graph got my colleagues very excited about the potential for us trying to minimise harm. So this was a snatch rescue. So this was a patient who was simulated to be in cardiac arrest when fire and rescue arrived. And you can see here, so number 1, just down the bottom here, this was the patient being stimulated. So this was a shout and a shake, trying to wake that patient up to see if they were alive or if they were dead. So you can see there's some movement there. And this is looking at movements in 3 different planes, so forward, backward, up, down, side to side. The second point you can see here is the patient having their belt unclipped, and that moved across. And the third is actually the removal from the car. So what you can see is that you've got about 2 Gs of force up on the right-hand side, which might sound like a lot, and it looks like a big spike. The other points on there are dragging the patient to safety, which is point number 4, and then 5 and 6 are a log roll. So in terms of actual forces that go through a patient when they have a motor vehicle collision, the maximum force you're likely to get is 7G from a 15 mile per hour collision. Okay, so that's quite a high force. So actually, the most force we're ever going to get through that patient is at the time of injury. It's not at the time of extrication. But if we're working on the principle of wanting to minimise harm, then I think it's fair enough to try and minimise those forces. So a controlled extrication is actually just slightly more than a snatch rescue. Okay, so there's no big difference. It's again around 2 Gs of force. So the force going through that patient is exactly the same, whether we slide them up a longboard or whether we controlled lift out. Now a rapid extrication, so this is effectively your plan B, where that patient has a longboard slid underneath their backside and then turned on the side, was actually the lowest out of all of them. So along the line, bottom, you can see we've got a time window. So this is a 0 to a minute. Now, a rapid extrication can be done in under a minute. A snatch rescue can be done in under a minute. But in 30 minutes, we're putting that patient through the same forces as we would do anyway. So we can make this shorter, okay? We can make it quicker and still put the patient through the same forces. And that way they're out, they can have their advanced interventions, and it also means that they're on their way to hospital. Okay, so it's a bit of a way, changing the way that we're thinking at the moment, is that actually, is this the right thing for us to be doing every time for every patient taking the roof on? Okay, so if we have a little think about intervention, so what sort of things can we be doing to these patients during their entrap period? Well, why interventions are we looking at it in the first place? Well, I did tell you I wasn't really going to talk political stuff, but response times. They are important. This is some work that Ben Brook has done with Tim. And this looked at combining ambulance data with fire data in terms of response to a postcode. So these were real cases that they looked at. So unsurprisingly, the fire and rescue services have phenomenal response times, and I do mean phenomenal response times to these incidents. An analysis of the last 3 years showed a response time on average of around 6 minutes. Now, of course, there's ones that fall either side, but as a median time, it's going to be about 6 minutes to get those that response there to see, which is absolutely phenomenal in my eyes. Now, the ambulance service response times have changed. Okay, they've changed over the years. And this is a graph from 2007 up to 2009. You can see that their response times have increased by about 3 minutes. Okay, now that's predicted to increase even further because of hospital delays, because of no change in funding but increased demand, lots and lots of different reasons. But what I really want to get across is the fact that you're quicker and you're there much sooner, and I'm sure that won't be a surprise to you in many cases. So from doing some simple maths, you've got about 5 minutes as a fire and rescue service where that patient is yours. Okay, you might not have any medical resources on scene in terms of the ambulance service. You're relying on what you have and what your knowledge is. So these are your patients. You have ownership of these patients, okay, and you are really, really important to them. So Tim had a look at a Delphie study, which is effectively an expert panel of 20 clinicians who were pre-hospital care consultants and emergency medicine consultants, and said to them, if there was a 5-minute delay in 10 of these interventions, which we'll look at in a second, which ones do you think are actually going to make those patients die? Or do you think is going to make them have a disability? So where do we need to be focusing our attention? And where do we need to be focusing all our efforts in terms of training? So what would affect them? Well, an obstructed airway was one of the interventions that they looked at. So in a patient who's unconscious, or in a patient who's got a severe central nervous system problem, they may well be unconscious, okay, and they're unable to maintain their airway. So if they're unable to maintain their airway, they're unable to get oxygen in, and they're unable to get CO2 out. So is that likely to be something that's going to affect that patient in the first 5 minutes? 100% it is. Okay, so absolutely consensus across the board. If that patient has got an obstructed airway that isn't managed in the first 5 minutes of someone being there, they're going to die, or they're going to have a much higher chance of dying. So what we need to be thinking about is ways that we can train fire and rescue service to make sure that they're absolutely 100% happy with how they open an airway and how they put in airway adjuncts. Now, a lot of this is already in the trauma care stuff that you guys do. But actually what we're thinking about is where we can really focus the training, really focus it so that we know that is right every single time. So high flow oxygen delivery. Now high flow oxygen delivery is something that's got taken a bit of a bashing in the medical literature recently. So actually we're trying to avoid what's called hyperoxia. So giving people too much oxygen in certain disease patterns. So if you have a heart attack or a massive myocardial infarction now, we're not going to slap you on high flow oxygen anymore because it makes that injury worse. That makes that insult worse to your heart. So we need to research a little bit more around what happens in trauma and whether every traumatic injury needs high flow oxygen. So this was put to those 20 clinicians. And there was a pretty bad split there, really. So in terms of priorities, they didn't think that in that first 5 minutes, applying a high flow oxygen mask was actually going to make that much difference to that patient. Now, that might not be the case 15 minutes down the line, but in that first 5 minutes, they thought there was other priorities that needed to be addressed. So hypoventilation. So use of a bag valve mask. Now, I don't know if any of you use these, but it's something that looks outwardly to be the most simple thing you can ever do in your life. You hold a mask on, you squeeze, air goes in, it comes out, beautiful. But actually it's really difficult, okay? It's a really difficult skill to master. And is this something that's actually going to make a huge impact? So getting gas in and out. Well, again, there was a massive split. Okay, so they don't think that actually in the first 5 minutes, being able to use a bag valve mask in a trapped patient is something that's actually necessary. Okay, what they think is we should be focusing our attention elsewhere. So thinking about opening an airway properly and perhaps focusing the team on getting that patient out, getting them somewhere that they can be actually tended to properly. So attention pneumothorax. I'm sure we've all had drilled into us how important this is. Okay, it's a disease process that means that the well, we initially thought it was due to reduced venous return to the heart, which it is in some patients, but often it's due to hypoxia. So these patients get progressively hypoxic and then actually they deteriorate. And would sticking a needle into that patient's chest in the first 5 minutes be something that would save more lives? Well, yeah, they did think that. Okay, so that's something that potentially is a technically difficult skill, but something we need to be thinking about more and more. Is this something that we need to be doing and training our fire service, fire and rescue personnel in doing in that first 5 minutes? Massive external hemorrhage. Massive external hemorrhage. In your trauma packs, I think you've probably got quite a lot of stuff that can arrest a massive external hemorrhage. And the sort of things that we'll be thinking about are tourniquets. So tourniquet use is back in fashion now. The use of hemostatic dressings, so the use of dressing that's actually going to promote clotting. And the use of things like indirect and direct pressure. So again, following up a hemorrhage control ladder. So would massive external hemorrhage make those patients die? 100%. Okay, so far we've got two things that have got almost unanimous support. We need to be focusing on controlling external hemorrhage, and we need to be focusing on how we're going to get those patients' obstructed airways open as the focus for the first 5 minutes. So pelvic fractures. Now, if you fracture your pelvis, it's a massively vascular organ, and it's got a massive vasculature there. And if you shear your pelvis, or if you smash it, there's a huge venous plexus that lives just around the back, which is basically all your veins returning the blood to your heart. Now, if you smash that pelvis, the chances are that that's going to have been damaged and you will bleed into that pelvic region. Now, some of the things that you might have heard of are pelvic splints. So, are pelvic splints something that could save patients' lives? Well, yeah, actually that is, and that's really important. And by putting those pelvic splints on, what we're looking at doing is pressurising the vasculature from the inside to try and effectively stop the bleeding. And also what that's doing is that's going to mean that the first clot that that patient forms is going to stay there because it hasn't got as much movement to move around. So pelvic fractures and the splinting of patients around the pelvis is something that we need to be looking at. So thinking about disability, we've got femoral fractures that can cause bleeding, but actually, quite commonly, in fact, the patient will lose their blood supply to their foot, or their nerves will become compromised. And in a patient who's got a femoral fracture with no foot pulse, is a pull on a leg and the application of a splint something that needs to happen quickly, or can it happen further on down the extrication line? Well, again, these 20 clinicians, they didn't agree on that. So I think the fact with that is that there's some discrepancy over at what point that damage is going to occur. Now, in the first 5 minutes, when you've got limited resources and that patient's trapped of pulling that leg, firstly, and then actually applying a splint to keep it there, is really, really difficult. And actually, we probably need to be looking at the other things before we do that. So hypothermia. Hypothermia, remembering what I've told you before, that the evidence is really strong, actually, that patients that are cold do badly following major trauma. So what sort of things could we do on scene to mitigate hypothermia? Well, is it as simple as putting a woolly hat on a patient? Does it mean we need to give them a big hug? Does it mean put a scarf around their neck? Does it mean we need to actively rewarm them with air-blowing blankets and things? Well, no one really knows what it is that's going to keep that patient's temperature warmer. But actually, they didn't think for 5 minutes that was going to make a huge difference. So whilst there might be some avenues that we can investigate in terms of hypothermia mitigation, actually for that first 5 minutes, it isn't too much of an issue. Pain. So in terms of pain, I'm sure we've all seen victims that have been trapped in cars that are in absolute agony. So would the effective relief of that pain affect their ultimate outcomes? And they thought probably, actually, there may be a chance that it would do. So is that something that we need to be looking at in terms of delivery of effective analgesia to make these patients more comfortable and lessen their suffering? Finally, psychological support. So there's reasonable evidence that actually by having good psychological support at the point of impact and someone talking you through what's happening next and supporting you and reassuring you that actually your outcomes will be better, at least from a morbidity perspective in the future. So might not affect if you're going to live or die, but it will affect the ability that you're able to function later in life and hopefully without any post-traumatic stress disorders. So would that make a difference? Well, not hugely, is what the Delphie study clinicians suggest. So in terms of the 5-minute focus, we've thought about the things that we might need to focus our attention and our training on for the near future. And basic airway manoeuvres and adjuncts and use of them is something that was unanimously decided to be important. Okay, so when we think about training modules and we think about drills and drilling people to be able to perform highly under levels of stress, actually this is something that we need to be focusing on. So teaching people how to manage an airway when the patient's lying down, teaching them how to manage it when the patient's sat partially up, teaching them how to do it when they're in a footwell. Okay, so all of these different situations, teaching them how to do it. Hemorrhage control is again huge. Okay, if that patient's trapped in that car and they can't come out, people need to arrest that hemorrhage. Now, like I said to you earlier, you might not be able to do all the Gucci stuff in terms of operations and things, but actually in terms of external hemorrhage, which is still a huge cause of death, we can do stuff about that. And the use of pressure, tourniquets, hemostatic dressings are something that we should be focused on and regularly drilled in so that we know how to perform them really well when we need to. The final one that got pretty much widely support was the use of pelvic binders. So I'm not actually too sure if you carry the pelvic binders at the moment. Dan, do you know? You don't have them at the moment. SAM splints. So SAM splints are exactly the same thing. So you have them, it's just knowing where to apply them, when to apply them, and how to apply them to patients in different scenarios. So to summarise, patients are important, really, really important. Trauma care is phenomenally important to try and prevent these patients. There's 50% of patients that are dying before they even get to hospital. So it's about what we can offer to them during that first hour. And some of those interventions will save lives. Final bit is that you're really important. Okay, very, very important in making sure that these patients have good outcomes. You're there earlier than everyone else. Okay, you're there before the medical services arrive. When they do get there, those patients need to be out of that vehicle. The only people that are going to get them out of that vehicle and get them on their way to hospital is fire and rescue. It's not going to be the ambulance service that do that. So in terms of minimising these deaths to this group of patients that die early in their trauma process, I would argue, and I would put up a strong argument, that the fire and rescue service actually have such a phenomenally key role to play in preventing those deaths. Any questions?